Welcome to Murder 360. Today we are diving into malaria, one of the world's deadliest infectious disease. What causes it, how does it spread, and most importantly, how can we treat and prevent it? So stay with me as we break it down in a simple and easy to remember way. And if you're finding these videos helpful, make sure to subscribe to Murder 360. Hit the bell icon so you never miss an important medical video. So without further ado, let's start. 3.2 billion people are at risk in 95 countries. That is about half of the world's population. 228 million cases were diagnosed in 2018 with about 4 lakh deaths. Malaria occurs throughout most of the tropical regions of the world. But Africa has about 93% of the malarial cases with about 94% of the deaths. Plasmodium falciparum predominates in the Africa and the New Guinea, while the Plasmodium vivax is more common in the Central and South America and Southeast Asia. Now let's talk about what causes malaria. Malaria is an infection with the protozoan parasites, which are a single-celled organisms that live in a host and cause disease, and these parasites belong to the genus Plasmodium. And in the genus Plasmodium, there are several species of Plasmodium which include Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. And all of these Plasmodium species are transmitted with the bites of female Anopheles mosquitoes. Only female mosquitoes transmit Plasmodium, as only females require a blood meal for egg development. Transmission in the absence of a mosquito is rare, but vertical transmission from mother to the child, transfusion, organ transplantation, or needle sharing can also result in the transmission of malaria. So, the infection malaria requires a biological vector, a parasite, and a host. The biological vector in that case is a female Anopheles mosquito. The parasite is Plasmodium species and the host is a human. Now let's talk about the Plasmodium species in detail. There are 5 Plasmodium species that results in human infections, but there are some other species that occurs in the primate that can also cause human disease. The Plasmodium species include Plasmodium falciparum, Plasmodium malariae, Plasmodium vivax, Plasmodium ovale, Plasmodium knowlesi. The other species that has also been known to cause human disease are Plasmodium cynomolgi, Plasmodium simium, and Plasmodium brasilianum. Now let's discuss some of the characteristics of the most common 4 species of Plasmodium that are falciparum, vivax, ovale, and malariae. At this stage, if you don't get these characteristics at all, don't worry. You will get to know them very well when I describe the life cycle of malaria. For the time being, just go with the flow and learn about the characteristic of different Plasmodium species. The first one is duration of the intrahepatic phase that occurs in the liver. The Plasmodium falciparum takes about 5.5 days, the vivax 8 days, ovale 9 days, and malariae 15 days. The second characteristic is the number of merozoite cells that are released from the infected hepatocytes. The falciparum about 30,000, vivax 10,000, ovale 15,000, and malariae 15,000 merozoites from the infected hepatocytes. Another important characteristic is the duration of the RBC cycles by the merozoites. The falciparum takes about 48 hours, vivax 48 hours, ovale 50 hours, and malariae 72 hours. The duration of the RBC cycle is crucial in malaria because it determines the timing of the fever spikes and the severity of the infections. The Plasmodium falciparum and vivax has a 48-hour cycle, so they have fever every 2 hours, tertian fever. Plasmodium ovale has a 50-hour cycle,
So it has also a fever every 2 days, but a slightly irregular pattern, tertian fever. And the Plasmodium malariae has a 72-hour cycle, fever every 3 days, also called cotton fever.
Another important characteristic is the morphology of the trophozoites of different Plasmodium species. Each Plasmodium species has a distinct trophozoite morphology which helps in the microscopic diagnosis. The Plasmodium falciparum has a small, delicate ring shape with multiple rings per RBC. The Plasmodium vivax trophozoites are large amoeboid with Schuffner dots and enlarged RBCs. The Schuffner dots are pink red granules. The Plasmodium ovale trophozoites are compact with oval RBCs and Schuffner dots. And the Plasmodium malariae trophozoites are compact, often band shaped with normal sized RBCs and Siemens dots. The next crucial characteristic is the ability to cause relapse, which is unique to Plasmodium vivax and Plasmodium ovale only due to their formation of the hypnozoites. These hypnozoites are dormant liver stage parasites that remain in the hepatocytes after the initial infection. But weeks to months later, they can reactivate and can undergo division and ultimately release merozoites into the bloodstream, leading to a relapse of malaria. That is why primaquine is a drug which is required for the radical cure, as they specifically target the hypnozoites in the liver, as we will discuss this later on.
These were some of the important characteristics of Plasmodium species. Now let's talk about how humans are infected by these Anopheles mosquitoes.
The human infection begins when a female Anopheles mosquito bites a human. It inoculates or injects plasmodial sporozoites from its salivary glands during a blood meal. These microscopic motile forms of malarial parasites are carried rapidly via the bloodstream to the liver, where they invade the hepatic parenchymal cells and begin a period of asexual reproduction, which is known as intrahepatic or pre-erythrocytic schizogeny. During this asexual reproduction, a single sporozoite may produce from 10,000 to greater than 30,000 daughter merozoites. Here, something different happens in Plasmodium vivax and Plasmodium ovale infections. A proportion of the intrahepatic forms do not divide immediately but remain inert for a period ranging from 2 weeks to greater than 1 year. These dormant forms of or hypnozoites are the cause of the relapses that characterize infection with these species. Now, the infected swollen hepatocytes eventually burst, releasing thousands of merozoites into the bloodstream, which then invades the RBCs, initiating the erythrocytic phase of the malarial cycle. Inside the RBCs, the merozoites develop into trophozoites, which further mature into erythrocytic schizonts. These schizonts rupture the RBCs, releasing more merozoites that infect new RBCs, leading to the characteristic symptoms of malaria, including fever, chills, and rigors. Meanwhile, some merozoites differentiate into male and female gametocytes, which are responsible for propagating the third stage of the malarial cycle in the mosquito. When an uninfected mosquito bites an infected human, it ingests these gametocytes, which reach its gut, where they transform into gametes and then fuse to form a zygote. And then zygote develops into an oocyst. The oocyst then release sporozoites, which migrate to the mosquito's salivary glands, making the mosquito capable of transmitting malaria when it bites another human. This completes the malaria life cycle.
Now let's go for a quick revision of the malaria life cycle. Malaria has 3 key phases, each crucial for its survival and transmission. Number 1 is the exoerythrocytic phase or the liver stage. The journey begins here when an infected mosquito injects sporozoites into the bloodstream. These sporozoites then invade the hepatocytes, multiply and mature into merozoites and schizonts. Eventually, the swollen hepatocytes burst, releasing thousands of merozoites into the bloodstream. Now, the erythrocytic or the blood stage starts, in which the merozoites invade the RBCs, developing into trophozoites and then schizonts, which rupture the RBC, releasing more merozoites and infecting more RBCs. This cycle causes fever, chills, and rigors, the hallmark symptoms of malaria. Meanwhile, some merozoites take a different path, maturing into male and female gametocytes, preparing for the next stage. Now, the third stage is the sporogonic phase or the mosquito stage. When a mosquito bites an infected person, it ingests these gametocytes, which travel to its guts and transform into an oocyte. The oocyte bursts, releasing into sporozoites, which migrate into the salivary gland, ready to infect the next human host. And just like that, the cycle continues. Understanding these cycles and these stages help in diagnosing, the treating, and preventing malaria effectively.
Now let's talk about the clinical features of malaria. It should be considered in anyone with fever who has previously visited a malarial area, regardless of the prophylaxis. The symptoms of malaria are non-specific, including fever, headache, malaise, myalgia, diarrhea, and even cough. The fever patterns are described but only occur if ruptures of the infected RBCs is synchronized. That is, alternate day for Plasmodium falciparum, vivax, and ovalve, also called tertian fever, and every third day for the Plasmodium malariae, which is known as quartan fever. But most patients have no specific fever pattern. Now, what about on examination? On examination, the patient may have fever, hepatosplenomegaly, pallor, and if the diagnosis is delayed or the disease is severe, they may present with jaundice, confusion, or seizures. Now, how do we diagnose malaria? There are two main ways to check for malaria. Number one is microscopy of the thick and thin blood smears. This is the gold standard of malaria. If done by an experienced person, it's highly accurate. The thick smear makes it easier to find the parasites, while the thin smear helps identify the specific type of malaria. The second test is the rapid diagnostic test. These tests detect malarial parasite antigens and are great for a quick initial screening, especially when expert microscopy isn't available. But remember that the rapid diagnostic test should always be used alongside blood smears and not instead of them. Ideally, results should be ready within 4 hours. Now, what if the first smear test is negative? If malarial parasite is still suspected but the blood smear is negative, don't rule it out just yet. The test should be repeated after 12 to 24 hours and again after 24 hours. If 3 expert blood smears came back negative, then the malaria is unlikely. Now let me discuss some conditions that mimic malaria presenting with similar signs and symptoms. So the differential diagnoses of malaria include dengue fever, typhoid or enteric fever, hepatitis, meningitis, encephalitis, HIV, and viral hemorrhagic fevers. As the saying goes, prevention is better than cure, and this holds true for malaria as well. Effective prevention not only reduces the risk of infection but also prevents complications and eases the treatment burden. Malaria prevention can be approached in 2 key ways. Number 1, vector control. This involves reducing the mosquito exposure by eliminating breeding sites like stagnant water, using insecticidal nets to prevent mosquito bites, applying indoor pesticide spray which can remain effective for 3 to 6 months, or using insect repellents in the form of coils, creams, or lotions. And the second way we can prevent malaria is by, for those traveling to malaria endemic areas, taking preventive medications that significantly reduces the risk of infections. This is called chemoprophylaxis. Common options include chloroquine plus proguanil, mefloquine, doxycycline, and atovaquone plus proguanil.
Now let's dive into one of the most important parts of today's discussion, that is the treatment of malaria. Treatment options include oral antimalarials for uncomplicated cases and parenteral antimalarials like intravenous or intramuscular for severe malaria or patients unable to take oral medications. After administering an oral antimalarial, the patient should be observed for at least an hour. If vomiting occurs during this time, the dose should be repeated to ensure proper absorption. Another key rule to remember is if there is any uncertainty about the Plasmodium species, always treat for Plasmodium falciparum, as it is the most dangerous form.
The treatment of malaria depends on identifying the infecting species. Let's break it down. Number 1, for treating Plasmodium vivax, ovale, and malaria, the WHO recommends either chloroquine or artemisinin-based combination therapy called ACT for these species. The chloroquine dosing is 10 mg per kilogram as a loading dose, followed by 5 mg per kilogram at 12, 24, and 36 hours. For the ACT, like an example, artemether and lumefantrine at a dose of 1.5 mg per kilogram and 9 mg per kilogram twice daily for 3 days. Now for treating Plasmodium falciparum, since the chloroquine resistance is widespread, WHO recommends ACTs as first-line therapy, including artemether lumefantrine, artesunate mefloquine, artesunate pyroneridine, and artesunate amidoquine. If the first-line treatment fails, the second-line options include a different ACT regime or artesunate or quinine plus any one of the following, including tetracycline, doxycycline, or clindamycin. And an alternative second-line treatment is atovaquone plus proguanil. Treating severe falciparum malaria requires parenteral therapy, which includes IV artesunate, IM artemether, and IV quinine infusion. Now let's talk about the radical treatment. Since Plasmodium vivax and Plasmodium ovale can cause relapses due to the dormant hymnocytes, radical treatment is essential. Primaquine is the drug of choice but must be given only after ruling out G6PD deficiency. The dosage is 0.5 mg per kilogram daily for 14 days with a total dose of 7 mg per kilogram. The same total dose can also be given in 7 days. Now finally, a last point. For Plasmodium falciparum, a single dose of primaquine at a dose of about 0.25 mg per kilogram is used to eliminate the gametocytes, and this is safe for G6PD deficient people as well. That wraps up everything about malaria treatment. I hope this explanation made it easier to understand. If you have any questions, feel free to ask in the comment section. And if you found this video helpful, like, subscribe, and share with your friends and family. Stay healthy, stay blessed, and see you in the next video.